What is the primary cause of differential cyanosis in a patient on VA-ECMO? A. Malfunctioning oxygenator. B. Competition between oxygenated ECMO flow and deoxygenated native cardiac output. C. High sweep gas flow. D. Low pump RPM. Answer: B. Competition between oxygenated ECMO flow and deoxygenated native cardiac output. Explanation: also known as Harlequin syndrome, this occurs in peripheral VA-ECMO when the heart recovers but the lungs haven't. The heart pumps blue blood to the brain and arms, while the ECMO pumps red blood to the lower body. Which monitoring site provides the best assessment of cerebral oxygenation in peripheral VA-ECMO? A. Left radial artery. B. Right radial artery. C. Dorsalis pedis artery. D. Femoral artery. Answer: B. Right radial artery. Explanation: the right radial artery, preductal, is the most distal point supplied by the heart's output. Monitoring the right radial POW2 or SAW2 ensures that the brain is receiving enough oxygen in the presence of competing flows. Which of the following is a potential complication of overventing the left ventricle, LV, during VA-ECMO? A. Pulmonary edema. B. Ventricular collapse and suck down against the vent cannula. C. Increased CO2 clearance. D. Systemic hypertension. Answer: B. Ventricular collapse and suck down against the vent cannula. Explanation: while venting the LV is necessary to prevent distension, excessive drainage can cause the ventricular walls to collapse around the cannula, leading to arrhythmias and poor flow. In ECMO management, the antithrombin 3 (ATIAI) level is critical because A. It is the primary fuel for the ECMO pump. B. Heparin requires ATIAI to exert its anticoagulant effect. C. It prevents hemolysis. D. It decreases the need for sweep gas. Answer: B. Heparin requires ATIAI to exert its anticoagulant effect. Explanation: heparin works by binding to ATIAI. If a patient is ATIAI deficient, common in sepsis or prolonged ECMO, they may appear heparin resistant, meaning their ACT or APTT won't rise despite high doses of heparin. What is the most likely cause of a sudden high pressure alarm on the arterial return line? A. Hypovolemia. B. A kink in the return cannula or tubing. C. Oxygenator failure. D. Reduced cardiac output. Answer: B. A kink in the return cannula or tubing. Explanation: high return pressure indicates resistance after the pump. This is usually due to a kinked line, a clamped line, or the return cannula being pushed against a vessel wall. Which change occurs to the mixing cloud in VA-ECMO when the patient's native cardiac contractility improves? A. The cloud moves more distally, down the aorta. B. The cloud moves more proximally, toward the aortic arch. C. The cloud disappears entirely. D. The cloud becomes larger. Answer: A. The cloud moves more distally, down the aorta. Explanation: the mixing cloud is the point where retrograde ECMO flow meets antegrade cardiac flow. As the heart gets stronger, it pushes the cloud further down the aorta, away from the heart. What is the bridge-to-bridge strategy in ECMO management? A. Using ECMO until the patient is ready for a kidney transplant. B. Using ECMO to stabilize a patient until a long-term VAD, ventricular assist device, can be placed. C. Switching from VV-ECMO to VA-ECMO. D. Moving a patient from one hospital to another while on ECMO. Answer: B. Using ECMO to stabilize a patient until a long-term VAD, ventricular assist device, can be placed. Explanation: bridge-to-bridge refers to using short-term support, ECMO, as a temporary measure until the patient can be transitioned to more durable mechanical circulatory support. Which of the following is a sign of oxygenator exhaustion? A. Low pressure drop across the membrane. B. Ability to maintain POW2 with low FiO2. C. Increasing POCO2 despite maximizing sweep gas flow. D. High pump RPM with low flow. Answer, C. Increasing PaCO2 despite maximizing sweep gas flow. Explanation. As the membrane becomes coated with fibrin and proteins, exhaustion, its ability to exchange gas, particularly CO2, diminishes, even with maximum sweep settings. In VV-ECMO, if the pump speed, RPM, is increased but flow, L/min, stays the same, what is the problem? A. The pump is decoupled or there is a massive clot in the pump head. B. The patient has become hypertensive. C. The oxygenator is working too well. D. The sweep gas is off. Answer, A. The pump is decoupled or there is a massive clot in the pump head. Explanation. In a centrifugal pump, if the RPM increases without a corresponding increase in flow, the magnetic coupling between the motor and the pump head may have failed, or the pump head is physically obstructed. Which of the following is a contraindication for decannulation in a VV-ECMO patient? A. VO2 on the ventilator is 30%. B. The patient failed a 2-hour sweep-off trial, developed respiratory acidosis. C. Platelet count is 150,000. D. Chest X-ray shows clearing of infiltrates. Answer, B. The patient failed a 2-hour sweep-off trial, developed respiratory acidosis. Explanation. A sweep-off trial is the gold standard for weaning VV-ECMO. If the patient cannot maintain normal pH and PaO2 with the sweep gas turned off, they are not yet ready for decannulation.